You let me know when we are starting.
Yes, yes, ma'am. A very good afternoon to one and all. I am Arpita, the moderator for today's session from the IGCP group. The topic that we are going to discuss today is male factor infertility, which refers to infertility issues that arise primarily from problems with the male reproductive system. I would request everyone to join us in this discussion on latest advancement, diagnostic approaches, and treatment options for male factor infertility, aiming to empower healthcare professionals with essential knowledge to better support affected individuals and couples. To address the topic, we have with us none other than Dr. Sushma Pampanavar ma'am. Ma'am has done MBBS, DGO. She's had DNB in obstetrics and gynecology. She has done diploma in gynecological endoscopy and reproductive medicine from the KIEL University at Germany. She is a gynecologist, an obstetrician, and infertility specialist at Ishwaya Fertility Center and Asia Hospital at Bangalore. So, with this very brief introduction of ma'am, I would request her to please start with her talk today. Over to you, ma'am.
Thank you, Arpita. So today I'll be just giving you a gist of male factor infertility. Usually, when a couple comes for us who are planning for pregnancy and who have been trying for pregnancy since the past 1 year, we try to evaluate them. Out of which, when we try to evaluate out of 100 people, one third of the couple accounts for of couple out of 100 people, one third of it accounts other one third accounts for female factor infertility, and the other one third accounts for combined factors. So, in this way, a male factor evaluation also accounts for evaluation whenever we plan for treatments for infertility. Coming to male factor infertility as such, we need to know about the specific anatomy of male factor infertility, wherein the male reproductive system has to be specified. Sperms are the one which combine with the eggs and form an embryos, which we all know. Where are the sperms produced? Sperms are produced from the testis, which is one of a gland located in the scrotum. From the testis, from the seminiferous tubules of the testis, the sperms are generated, which are traveled via a tube called epididymis, which later forms a vas deferens, and then which enters into the urethra, and via the penis, the sample, the ejaculated. So why do I want to stress about this male factor infertility is when a husband, when a husband is evaluated, we check for semen analysis. Whenever we check for the semen analysis, we check for the sperm count, the sperm motility, and the sperm morphology. That is, the sperm has a head, a neck, a mid piece, and a tail. So all these factors, the sperm count, the semen motility, and the sperm morphology accounts for it has to be good. Only then a couple or a male can be fertile. So in this way, whenever we speak, or if the semen sample in the semen analysis, if there are no sperms, we need to know about we need to know about why the semen sample, the sperms are absent in the semen. Why? Because it could be a testicular cause, or it could be a post testicular cause, wherein the sperms itself are not produced from the testis. That is, we call it as a testicular failure. Or the sperms are produced, but they are not able to travel via the epididymis or the vas deferens. That is post testicular cause. So, why are we interested in learning all these? Why are we interested in evaluating all these? Is depending upon the cause of semen analysis. In the abnormal semen analysis, we can advise them the further treatments. Before knowing the treatments, let us first know what are the causes. As I already told, the semen abnormalities could be because of pre-testicular, testicular, or post-testicular causes. Post-testicular causes, which I already elaborated, the obstruction in the epididymis, the vast difference because of some abnormalities, that is they would not have not formed, which we call it as aplasia or vasectomy. The tubes itself has been blocked because of some family planning operation or whatever it is, or some abnormality of the ciliary problems in the tubes would have been the usually the vast difference has microscopically we see ciliary motility. If there is some ciliary motility problems, the sperm will not be able to travel. They are trapped inside the sperms, inside the testis, or because of a varicocele wherein the nerves become enlarged and the sperms are not able to ejaculate or not able to produce. These are some of the post testicular causes. What are the causes for pre-testicular testicular causes? Testicular causes, again, the ciliary motility problem, like cystic fibrosis, or genetic problems wherein Y chromosome deletions or some micro deletions of some chromosomes, Klinefelter syndrome, genetic problems is what I am speaking. Then other sedentary lifestyle habits such as smoking, alcoholism, or some genetic causes, or some pituitary causes, because FSH and follicle stimulating hormone and luteinizing hormones are the ones which help, which are produced from the brain, that is the hypothalamus and the pituitary, which helps for the testis to produce the sperms, that is the seminiferous tubules in the testis which helps to produce the sperms, that is hypogonadotrophic hypogonadism, that is abnormalities of FSH and LH hormones. Not only these, some intake of drugs or sedentary lifestyle habits are related to occupation, like agriculturists who put the pesticides and all, or drivers. So, again, the smoking and all these affect the sperm count, the motility, as well as the morphology, which I already mentioned. So what was so after the cause, after knowing the causes, how do they present? How do they present? Male factor infertility, how do they present to us? Usually they are asymptomatic until and unless we test by the semen analysis, or they may present as some heaviness in the scrotum, like because of varicocele and all that. And these are usually they are asymptomatic until and unless we test, or until and unless we do some genetic tests or semen analysis. Coming to again the evaluation part as per se, which I was already telling about the semen analysis. The most important evaluation is, first one is the semen analysis, which has to be done in a proper way. That is 3 to 5 days of abstinence before giving the sample for semen analysis in a wide mouthed clean container. The sample has to be collected either by masturbation or by home collection, wherein the sample has to reach within the lab within 30 minutes. A good lab which analyzes the sperms, we whenever the sample is given, we allow the sample to get it liquefied, which takes the normal, the WHO semen analysis accounts for within 20 to 30 minutes is a normal liquefaction time which we allow. And then the sample is, one drop of the sample is just put on the Mackler's chamber or the Newbur's chamber, and the sperm is counted, the number of sperms. WHO recommends the normal semen count to be 15 million per ml, the progressive motility to be 32%, and the normal forms, that is, which I also already told you, to be 4%. With these three factors, mainly these three factors, try to please remember the count of 15 million per ml, the progressive motility of 32%, and the normal forms of 4%. We label the sample as normospermia. If at all the count is less, we call it as less than 15 million, we call it as oligospermia. If at all the motility is less, the progressive motility is less than 32%, or total motility that comes to progressive motility plus immotile sperms that comes to 40%, if it is less than that, we call it as asthenospermia. And if the normal morphology is less than 4%, we label it as teratospermia. And if there are there are no sperms as such, we label it as azoospermia. There are no sperms in the sample, which we label it. So whenever we label these we as abnormalities, that is oligoastenospermia, oligoastenoteratospermia, and all these, we further go for the next step of evaluation, that is male hormonal blood tests, that is serum follicle stimulating hormone and serum luteinizing hormone, male serum prolactin, serum thyroid stimulating hormone as a basic evaluation, along with, if needed, serum testosterone, total as well as free testosterone levels, as well as free serum estradiol levels also. So, the first thing which I already told you, the semen analysis, if any abnormality needed based upon the severity, we check for male TSH, prolactin, FSH, LH, serum total testosterone, serum free testosterone, and serum estradiol levels. Along with these blood tests, we even evaluate for transrectal ultrasound. We call it as TRUS. Along with that, we can even jump for diagnostic procedures such as testicular biopsy, also if needed based upon the evaluation of the blood tests. Coming to the treatment part per se, as I already told, based upon the semen analysis, specifically the azoospermia, which I want to elaborate, males, when we tell there are no sperms, they are really disheartened. What next? So whenever we analyze the semen analysis, uh, based upon the semen count, the sperm count, as I already told, 15 million per ml, along with progressive motility of 32 and 4% normal forms. If there is mild oligospermia, that is the sperm count being 10 to 15, we can give them the further treatment of IUI, wherein there are sperm processing techniques like swim up method, density gradient method, and other methods as well, wherein the sperms, the sample which is given, is processed, is washed, and only the good motile sperms with good count are swimmed up after processing, and that sperms are collected and injected into the female uterus via a small tube, which we call it as IUI catheter, and a couple can be helped to plan a pregnancy. We can help them to give a pregnancy. Though the success rate is just 15 to 20%, we can still go ahead and try for IUI for 3 or 4 cycles. Of course, the sample should be mild to moderate oligospermia. Coming to very severe oligospermia or asthenospermia or teratospermia, these men usually need a further step of treatment, that is IVF ICSI, wherein the female partner is given injections for her follicles to become big, that is dominant follicles that are on 20 to 12, 18 to 20 and on the a series of injections are given for 10 to 11 days, and a final trigger injection is given for the final maturation of the egg, and a procedure called egg pickup is done, wherein under short general anesthesia, needle is pricked via the ovary, which enters the follicles, and the ovary and the oocytes, that is the eggs, are aspirated, and those eggs are mixed with the sperms. Even though the sperm count is very, very minimal, that is occasional sperms, even if they are seen, we can take those sperms and inject directly into the a oocyte. So this is one of a procedure needed for those who suffer from very severe oligospermia. Think sperm count being less than 4 million, 2 million, 1 million, or very occasional motile sperms. Or men suffering from asthenospermia, progressive motility is very nil, or teratospermia, wherein abnormal forms are too much, we can select the sperms and inject into the egg. And once we inject, we culture it tries to form an embryo. We culture it for 3 to 5 days, and the resultant embryo, which we call, that is nothing but the baby itself, embryo we call, that is again transferred back into the uterus. So this is one of our treatment options for very severe oligosteroteratosphermia, which we call it as IVF ICSI. Count is totally nil, that is azoospermia. If there is azoospermia, we go back and see the blood reports, or the again repeat the semen analysis, confirm that it is azoospermia, and based on the blood reports, that is FSH, LH, TSH, testosterone and prolactin levels, we advise them reports, we advise them a procedure called as TISA, wherein on the testis and the sperms are taken out from the seminiferous tubules, and the resulting sperms, if they are present, will be mixed with the egg, that is nothing but ICSI will be done. Mixed with the egg, and the resulting embryo will be transferred back. So what are the methods of obtaining the sperms? One, which I already told it as TISA, that is testicular sperm aspiration. Other procedures such as PISA, that is percutaneous epididymal sperm aspiration, and microsurgical epididymal sperm aspiration. These are some of the sperm retrieval techniques. And even tubules can be teased the semen as give own self own release to them, following these advanced IVF techniques. So what are the other gonadotrophin, human chorionic gonadotrophin, that is HCG injections, can be given for the male factor in infertility based on the semen analysis. With all these advances, we can plan to give their own genetic babies to the couple. Ultimate, or if at all, if it is a clear cut case of testicular failure, wherein we cannot get the sperms, that is, we are not able to inject the sperms into the
I would request everyone to please be patient. I think there is a network connectivity issue from our QoS end, so I would request everyone to please be with us. Ma'am will be joining shortly for the session. Thank you all for your patience. I think ma'am is facing some connectivity issues. Yeah. So, yes, yes, ma'am. Please continue.
That is what, with all these, I think I come to a conclusion with starting from the incidence of the male factor infertility, the causes, the signs and symptoms, the evaluation of male factor infertility, and the treatment part. If any questions are there, I would like to ask. I joined via phone.
Okay, okay, ma'am. No problem, no problem. So, ma'am, let me take. There is only one question that we have received. That is, what are the key challenges that you have faced in managing the male factor infertility cases, and how do you overcome them in your practice?
Out of 10 people who visit my clinic, uh, around 4 to 5 come with male factor infertility itself. Either they would be for just for evaluation who come, or they come with the reports itself in the hand. What next is the question. So whenever, and the difficult ones for us to handle is these azoospermia, wherein if at all they have testicular failure, and there are no chances that the sperms can be retrieved, so it is very difficult for us to counsel them regarding what next is the procedure. Because though we can challenge them with the hormones and all, it is very difficult for us to get the sperm retrieval techniques even with these advanced. So in that way, our main difficulty comes with these, wherein we need to suggest them the donor semen and all that, which will be a bit difficult to take. And other than these, most of them have many lifestyle changes which they adopt in their this thing. So for us, we have to compel on them for to do changes in their lifestyle, and we have seen that, and they do work out also. So these are the two main changes which we usually advise them.
Right, ma'am. Thank you, ma'am. Thank you so much. So, with that, we come to an end to this webinar. Thank you so much, ma'am, for putting your insights into the topic, and thank you for putting your time and your knowledge into it. Thank you. Thank you. Thank you all for attending the session.
Thank you.